Hello students, so now let's start with cell wall inhibitors and cell membrane inhibitors part 2. So in this section we will start with antimicrobials like cephalosporins, carbapenems, monobactams, a very important glycopeptide group which will contain vancomycin. And after cell wall inhibitor, we will also discuss about the antimicrobial that will inhibit cell membrane of a bacteria, in which we will discuss daptomycin, colistin, etc. So first, let's start with cell wall inhibitor. So in the previous section of part 1, we discussed all cell wall inhibitor. The mnemonic was BBC getting famous, in which we discussed about beta-lactam group. And in beta-lactam group, we have already covered penicillin in part 1. So in this section of part 2, we will be discussing rest all other cell wall inhibitor. So we will start with cephalosporin, carbapenem and monobactam. So they are also beta-lactam group of antibiotic, and we will discuss rest all other cell wall inhibitor. Now one point to begin with cephalosporin, one point we must remember that all these drugs which are cell wall inhibitors are bactericidal. That means they produce complete killing of bacteria. So they all are cidal drug except one drug, cycloserine. So cycloserine is not a cidal, it is rather bacteriostatic drug. So with this note, let's start first with one beta-lactam group of antibiotic, that is cephalosporins. So cephalosporins, they are divided into 5 generations, first to 5th generation, and let's see each generation where they are used and how we can remember their names. So first generation cephalosporin, among all cephalosporin, they are the best drugs we have for gram-positive bacteria or gram-positive infection. So we know Staphylococcus is a gram-positive bacteria. Even Streptococcus is also a gram-positive bacteria. So they are given to kill Staphylococcus and Streptococcus. But remember, there is one strain of Staphylococcus known as MRSA, which we discussed previously, methicillin-resistant Staphylococcus aureus. In this MRSA, they are not effective. And all other strains of Staphylococcus, yes, they are effective. And these drugs are considered to be the drug of choice for surgical prophylaxis. First generation cephalosporin, they are the drug of choice for surgical prophylaxis. Now, what do you mean by this word? Imagine we are doing surgery in a patient. Don't you think we have to give a skin incision? On our skin, we have Staphylococcus and Streptococcus bacteria. And if we give an incision, don't you think during our surgery, from skin, this bacteria can enter into the blood? So we want that during surgery, this bacteria should not come into the blood. This is known as surgical prophylaxis. So these drugs must be given 30 minutes prior to surgical incision. So before giving surgical incision, give 30 minutes prior so that these Streptococcus and Staphylococcus should not enter into the blood. So now the next question, the tough one, how to remember their name? It is very easy. So any cephalosporin which starts with the word Cepha will be first generation. Now this Cepha could be CEFA or CEPHA. So Cepha word will come, it will be first generation. Remember one exception. The only exception is cefaclor. So if a word cefaclor comes, remember it will not be first generation. Cefaclor will be second generation cephalosporin. Rest any cephalosporin with cepha word will be first generation. So let's see what are the drugs we have. So among oral drug, first generation cephalosporin, we can write cefalexin, cefadroxil, and cefaloridine. Among parenteral, a very important drug which you must remember is cefazolin. Very commonly asked question. So cefazolin, straight away question comes. It's a first generation cephalosporin. And now can you tell me the uses of cefazolin? Cefazolin is the drug of choice for surgical prophylaxis. Now let's talk about second generation cephalosporin. Second generation cephalosporin, they have the best activity against anaerobic bacteria. Anaerobes means which are not dependent upon oxygen for their growth. Now, what about gram-positive and negative bacteria? Sir, they are less effective against gram-positive. Remember, the best drug against gram-positive is first generation cephalosporin. Second point, they have less effective against gram-negative. Remember, the best drug against gram-negative bacteria is third generation cephalosporin. So where they are used, they are mainly given for the treatment of one anaerobic bacteria, that is Bacteroides bacteria. But it is not the drug of choice. Remember, wherever the word anaerobic bacteria comes, always the drug of choice is metronidazole. So any anaerobic bacteria give metronidazole, but yes, second generation cephalosporin are also effective. So what are the drugs? First drug we already know is cefaclor. So it is starting with the word cefa, which is an exception. It is not a first generation, it is rather a second generation cephalosporin. Then we have another drug, that is cefuroxime, and its prodrug is Exitil. Now, if you remove this Exitil word and just write cefuroxime, it becomes a parenteral or injectable drug. And lastly, an oral drug is loracarbef. So if you will not remember this drug, loracarbef, it will be fine for you. But remember, carb word is coming, it is a type of carbapenem. Now, other parenteral antibiotics in cephalosporin, which are second generation, remember a mnemonic MTX, that is cefmendol, cefotitan, and cefoxitin. And these cephalosporins, they are the best cephalosporin MTX against bacteroid. So these are the second generation. Now remember, do you think second generation will have any much use? Are they popular drug? The answer is no. Because if we want to kill gram positive, first generation is better. If we want to kill gram negative, sir, third generation is better. And if you want to kill anaerobe, we have another drug, that is metronidazole. That is why second generation are less commonly used. What is more commonly used is third generation cephalosporin. And third generation cephalosporin, they have the best activity against gram negative bacterias. Gram negative bacterias. And they are considered to be the drug of choice for community acquired gram negative infection. So can you tell me certain gram negative bacteria which spread in community? Can we say, sir, salmonella? Salmonella causes typhoid. It spreads in community through contaminated food. Similarly, we can write meningococci, which is caused by Neisseria meningitidis. It can spread. Gonococci, which is a sexually transmitted disease caused by Neisseria gonorrhea, a gram-negative bacteria. Similarly, we can write Haemophilus influenza, which can also spread through air droplets, can cause respiratory tract infection, pneumonias, and meningitis. So don't you think any gram-negative infection which spreads in community, drug of choice is always third generation cephalosporin. So for typhoid, meningococci, we give this drug. So how to identify their name? Very easy. Third generation cephalosporin, remember a word, either they will end with the word zeme or zon. But again, there is an exception. Any drug ending with the word zeme and zon will be third generation cephalosporin. Another exception which we have already discussed is cefuroxime. Cefuroxime, it is ending with the word zine. It is not a third generation, it is rather a second generation cephalosporin. So can we say that all exceptions are in second generation? So this is a point must be remembered. So what are the oral drug we have in third generation cephalosporin? Very easy to identify, cefixime. Similarly, another drug is cefopodoxime. And among parenteral, it's a very commonly asked question, ceftriaxone. Zone word is coming. Cefotaxime. So we can easily identify zeme and zone word very easily. So if I will ask you, sir, what is the drug of choice for dangerous meningococcal meningitis? You have to give an injectable drug. Don't you think you will give ceftriaxone or cefotaxime? What is the drug of choice for H influenza, gonococci and typhoid? Always ceftriaxone. And if I will ask you a question, can you tell me an oral drug for gonorrhea and typhoid? Sir, you will say cefixime is an oral drug for gonorrhea and typhoid. So just identify the bacteria if it is a gram-negative bacteria. And if it spreads in community, give third generation cephalosporin. But the point to be noted is, all these cephalosporins which are ending with the word zeme and zon, they are not effective in 1 gram negative infection. In which gram negative bacteria they are not effective? Ceftriaxone like drug, they are not effective in Pseudomonas. That is why we have made new third generation cephalosporins which can even kill Pseudomonas. So sir, how to identify them? Very easy. Just identify the last alphabet Z. They will have Z alphabet in them. So the drugs are ceftazidime. So we can easily see Z word is coming. Cefoperazone. Again we can see Z word is coming. Cefoperazone. And a new drug, ceftolozane. So can we say, sir, in this section we can see Z word is coming. So any cephalosporin having Z alphabet in them is anti-Pseudomonas. It can kill Pseudomonas bacteria. Do you think ceftriaxone is having Z word in it? Sir, no. So it is not effective against Pseudomonas. Cefixime, no Z word, not effective against Pseudomonas. So it's a very easy to identify, but recently we made certain new other drugs. So certain new other cephalosporins which are also given in gram negative infection are moxalactam. So these are just for reference. Moxalactam, just like ceftriaxone, and another drug which can be given for Pseudomonas is cefidercol. So cefidercol, a new cephalosporin which is effective against Pseudomonas, a new third generation. Now one point is important. Now you can see cefidercol, some der word is coming. It contains a special siderophore ring. So siderophore ring is an iron containing ring. Siderophore means iron containing ring. With the help of siderophore, it can also kill a bacteria. So these are the new drugs, just we can remember for reference. So all these drugs are parenteral drugs. Z-wale drugs are also parenteral drugs. Among them oral we have only two drugs, cefixime and cefopodoxime. Now let's talk about fourth generation cephalosporin, how we can remember them. Fourth generation cephalosporin are just like third generation cephalosporin. they are given for gram-negative infection, just like third generation. But sir, what is the difference? Third generation were given for community-acquired infection, but fourth generation cephalosporin, they are rather given for hospital-acquired infection. So don't you think in hospital acquired infection, let's say a person is on ventilator, we have put a Ryle's tube, or if we have put a Foley's catheter, all these intervention can lead to infection. And in hospital, you will find very resistant bacteria. These bacteria are resistant to antibiotics. So we have fourth generation cephalosporin. Why? Because it is not degraded by or it is resistant to beta lactamase enzyme. So in the previous section, we discussed that beta lactamase enzyme degrades beta lactam group of antibiotic like penicillin, cephalosporin. So because they are resistant to beta lactamase enzyme, they are given for resistant bacteria, and resistant bacteria are seen in hospitals. So what are the drugs we have? How to identify? Very easy. Fourth generation cephalosporin, just identify the word pi. Pi word will come in them. So the first drug we have is cefepime. So we can see pi word is coming. And the second drug we have is cefepirome. Again, pi word is coming. So these cephalosporin, they are only and only parenteral. That means they can be given intravenously or they are given as an intramuscular injection only. They are not given orally. So they are only given by injection. Now lastly, we made fifth generation cephalosporin. And fifth generation cephalosporin is the only drug we have which is effective against MRSA bacteria. So MRSA, in the previous section we discussed in great detail, it is methicillin resistant Staph aureus. So it is the only beta lactam which is effective against MRSA. No other beta lactam, penicillin, cephalosporin, carbapenem, no other drug is effective in beta lactam group against MRSA. So how to identify fifth generation? Very easy. Identify the word rol. Rol word will come, and these cephalosporins are ceftaroline and ceftabiprole. So very easy to identify them. So remember, you have to identify. If you will not remember their name, it will be fine. Again, these cephalosporins, they are given by injections only, and they are only given as an intravenous injection. So this is all the generations of cephalosporin. So now let's talk about properties of cephalosporin. Now, which cephalosporin has maximum brain penetration? So first property, which cephalosporin has maximum brain penetration? So beta, just identify Zim word in them. Zim cephalosporin have a very good brain penetration. So the best brain penetration will be cefotaxime. That is why it is preferred in cases of infections like meningitis. Another drug you can write, cefuroxime. So this cefotaxime was third generation cephalosporin, while cefuroxime was an exception, it was second generation. Now, which cephalosporin is safe in renal disease patient? So in this case, just identify the word on. So safest cephalosporin in renal disease is cefoperazone. And if cefoperazone is not given in the option, go with ceftriaxone. So one question arises, sir, why they are safe in renal disease? Because these cephalosporins, they are not excreted in urine. They are rather excreted in bile. So if they are excreted in bile, do you reduce the dose of these cephalosporin in renal failure? So that is the great advantage. No dose reduction in renal failure. So they are safe in renal disease patient. But because they are excreted in bile through liver, bile comes through liver. So because they are excreted through bile, these cephalosporin has a side effect. These cephalosporins, they can cause jaundice or hyperbilirubinemia. They increase bilirubin level. And in neonate or a small child, remember, if bilirubin level gets increased in neonate, these cephalosporins increase in bilirubin damages brain. They can increase the risk of kernicterus. So can we say they must be given in renal disease, but avoid them in liver disease? So next question is, which cephalosporin can cause disulfiram-like reaction? And remember, any drug which causes disulfiram-like reaction must be avoided in people who drink alcohol. And which cephalosporin reduce fibrin level? Remember, fibrin is a clotting factor. And if the levels of fibrin is reduced, can we say the risk of bleeding will increase? And there is a similar drug which also reduces fibrin level and can cause bleeding. That is warfarin. So warfarin toxicity will increase, the risk of bleeding with warfarin will increase. So again, in this case, both cases, the answer is cefoperazone. So don't you think we have written cefoperazone above also? So if I'll ask you a question, which is safe in renal disease, you will say, sir, cefoperazone. Which causes disulfiram-like reaction? Sir, cefoperazone. Which should be avoided with warfarin because it can cause risk of bleeding by reducing fibrin level? Again, you will say, sir, cefoperazone. So everywhere cefoperazone word is coming. Now, there are certain other antibiotics as well which can also produce disulfiram and reduce fibrin level. So other are MTX, which we have written, cefamendol, cefotitan, and cefoxitin. So these are also certain cephalosporin which can cause disulfiram-like reaction. But what is important for you? Try to remember cefoperazone. So sir, how we can remember cefoperazone? Let's make a trick. Cefoperazone. So first point is a very famous word, opera is coming. Now imagine when you are in opera, when you are hearing that beautiful music, what generally have in our hand? Sir, we drink alcohol when we listen through opera. So can we say, so opera means when we are listening music, we drink alcohol. So alcoholics, it must be avoided. It can cause disulfiram-like reaction. So this is a very important point that you must remember. Now, in cefoperazone, ERA word is coming. ERA word is coming means ERA. A for avoided in alcoholic. It can cause excess bleeding because it decreases fibrin level. And R for it is renal safe. So this is a technique how to remember cefoperazone, ERA word or opera word you have to identify. Now, which cephalosporin can damage brain and can cause encephalopathy? Cefepime. Now, all cephalosporins, first to fifth generation, all cephalosporins are not effective against 4 infection. So the first infection is Listeria infection. So in Listeria, remember, no cephalosporin is effective. In Listeria, we discussed the drug of choice was ampicillin. So this Listeria causes meningitis. All cephalosporins are not effective against atypical bacteria like Mycoplasma because Mycoplasma like bacteria, they lack cell wall. Cephalosporins, they inhibit cell wall. Now they are not effective against MRSA and they are not effective against Enterococci. So Enterococci, remember, it can cause endocarditis and UTI, and in this section we are discussing the treatment of Enterococci. So what is the treatment of mycoplasma? We prefer to give a drug azithromycin. So MRSA, remember all cephalosporins are effective against MRSA except fifth generation cephalosporin. So fifth generation cephalosporin is effective against MRSA, but the drug of choice for MRSA is, we have discussed in previous section, vancomycin. And same vancomycin can be given for the treatment of enterococcal infection. So these are the lame where cephalosporins are not effective. Now let's talk about use of one cephalosporin, ceftazidime. Sir, Z word is coming. So I have told you any cephalosporin having Z word in it is given for the treatment of Pseudomonas. So Pseudomonas aeruginosa. But Pseudomonas has one more species, Pseudomonas pseudomeli, which can cause one disease, melioidosis. So remember, melioidosis, a pseudomonal infection, treatment of choices, Z-Wali, cephalosporin, ceftazidime. So this finishes our cephalosporin, but before starting with the next drug, let's clinically correlate. Let's understand in which infection which drug to be used. Remember one rule, any gram-negative community acquired infection like typhoid, Salmonella typhi, meningococci and gonococci caused by Neisseria meningitidis and Neisseria gonorrhea, and Haemophilus influenza. So any community acquired gram-negative infection, the drug of choice is third generation cephalosporin. And if third generation cephalosporin is not given in the option, you can go with extended spectrum penicillin. So third generation cephalosporins were like ceftriaxone, which is given by injection. And if I'll ask you one oral drug for typhoid, you will write, sir, cefixime. Cefixime is an oral drug for gonococci, typhoid, etc. And if extended spectrum penicillin word will come, you can write ampicillin, amoxicillin, piperacillin, which we have discussed in previous section. But overall drug of choice is always and always third generation cephalosporin. But what happened with time, these bacteria are developing resistance against these third generation cephalosporin and extended spectrum penicillin. And in resistant cases, we can straight away start. In resistant cases, we can straight away start as a drug of choice carbapenems. Because carbapenems, they are not degraded inside the bacteria by enzymes, which we have discussed in previous section. Yes, sir, you can give fourth generation cephalosporin as well. Because fourth generation cephalosporin, they are not degraded by enzyme, but drug of choice is carbapenem in resistant cases. Now, next type of infection is hospital acquired infection. So in hospital acquired, let's say a patient is on ventilator, patient is having some IV lines, patient is having urinary catheter. All these things can lead to infection. Now, hospital acquired infection is by very resistant bacteria. And most of these bacteria names are very difficult. Probably you have not given much attention to them. So if I say Klebsiella, do you think Klebsiella infection occurs in community? From you to any other person? Rarely. Pseudomonas, Acinetobacter baumannii, ventilator associated pneumonia. Similarly, very peculiar names like Burkholderia capacia, Serratia proteus. So any different name comes which you have not heard very commonly. These infections are hospital acquired infection, and for hospital acquired infection, the overall drug of choice is carbapenems. Straight away start carbapenems or fourth generation cephalosporin. So if I'll ask you a question, sir, drug of choice for Acinetobacter baumannii, you will say, sir, a very peculiar bacteria, rare infection, Probably it will be causing infection in hospital. Sir, the drug of choice is carbapenems. So similarly, Pseudomonas and Klebsiella. But now, sir, the story doesn't end here. These bacteria are becoming resistant to even carbapenems. So, in carbapenem resistant cases, we will be discussing a very important drug, that is colistin. So, we can give colistin in carbapenem resistant cases, and this colistin is now considered as a drug of last resort. That means after colistin, we are out of option to kill a bacteria. But the truth is, we are even finding resistant cases of colistin as well, which is a big problem, and we are getting out of options. So that is a thing which as a human and as a future doctor you should work on. So let's talk about keeping this thing in mind, carbapenems. So in carbapenem, any drug, remember, it will end with the word penem. Penem word will come. So very famous drug, imipenem, meropenem, doripenem, ertapenem, pharopenem. So all these first drugs, they are given by injections. They are given IV. But which carbapenem can be given like food? Food means oral. F for food, F for pharopenem. Pharopenem can be given orally. Now, what is a great advantage of carbapenems? Carbapenems are resistant to degradation by beta lactamase enzyme. That is why they are not degraded in the bacteria. They are the drug of choice for hospital acquired infections, which is also known as nosocomial infection. Now, one important point you must remember, there is a very bad drug, ertapenem. This ertapenem is not effective in Pseudomonas and it is not effective in Acinetobacter, which we have just discussed previously. But this ertapenem is not effective, so it is less commonly used. So what is the main side effect of carbapenem? So carbapenem, their first side effect is they are highly neurotoxic molecule. And in neurotoxicity, remember, they can cause seizures. And second side effect of carbapenem is they are nephrotoxic. They can damage kidney. Neurotoxicity and nephrotoxicity. One recent question came that among all carbapenem, which is the most toxic carbapenem? The first one is most toxic. Most toxic carbapenem is imipenem. Most toxic carbapenem is imipenem. Now, how imipenem is toxic? Let's understand this part. Sir, this imipenem, it goes to kidney, and from kidney, it gets converted into a very toxic form. Kidney converts imipenem into toxic form, which can damage kidney, which can enter into brain and cause neuronal damage. So there is an enzyme in kidney which converts imipenem into toxic form. The name of the enzyme is DHP1 enzyme. DHP1 stands for dihydropeptidase enzyme. So that is why, don't you think there is a need of inhibiting this enzyme? That is why this imipenem, it is always combined with a drug known as cilastatin. Imipenem, it is always combined with a drug cilastatin. So what is this cilastatin? Cilastatin inhibits the enzyme DHP1 enzyme in kidney. Can we say cilastatin prevent the conversion of imipenem into toxic form? So the great advantage of combining cilastatin is that it reduces the toxicity of imipenem, like nephrotoxicity, neurotoxicity, plus it also makes imipenem longer acting. So imipenem also becomes longer acting because it will not be converted into any other form. So this is a very important point. Now let's talk about that story which we missed. Slowly and slowly, certain bacteria, they are becoming even resistant to carbapenems. So there are certain bacteria which are making an enzyme known as carbapenemase enzyme. So carbapenemase enzyme, remember, if produced in bacteria, it degrades carbapenems. So this carbapenemase enzyme, remember, it is also known as metallo beta lactamase enzyme. And this enzyme, if produced by bacteria, carbapenems will not be effective. So those bacteria which are producing this metallo-beta lactamase enzyme, the first bacteria name is Delhi superbug. So Delhi superbug, it was first identified in Delhi, Sir Gangaram Hospital or AIIMS Delhi Hospital. It was a strain of E. coli which was producing this carbapenemase enzyme. And this Delhi superbug was also known as New Delhi metallo beta lactamase producing E. coli. New Delhi metallo beta lactamase strain of E. coli. Similarly, we have CRAB. In CRAB, CR stands for carbapenem resistant Acinetobacter baumannii. So it's a very big problem in our hospital. Similarly, CRKP. CRKP will be carbapenem resistant Klebsiella pneumonia, a gram-negative infection. And lastly, CRPA, it will be carbapenem resistant Pseudomonas aeruginosa. So these are certain strains of bacteria which are even now resistant to carbapenem. So here comes the question. Sir, how to treat these bacteria like Delhi superbug, Acinetobacter, crab bacteria? Treatment is give colistin. So we can give colistin as a drug of choice. But apart from colistin, another drug which we can remember is tigecycline. Another drug we have is tigecycline. But for this Pseudomonas aeruginosa, we have one more drug. Now the drug of choice for carbapenem resistant Pseudomonas aeruginosa is ceftazidime. क्योंकि Z word is coming, so it is a anti-Pseudomonas cephalosporin combined with one beta lactamase inhibitor, avibactam. So avibactam we discussed in the previous section. It inhibits beta lactamase enzyme, metallo beta lactamase enzyme. So what is a common drug which can be given overall to all these bacteria? Remember the word colistin. Colistin is given in carbapenem resistant cases. So now let's talk about last beta lactam group of antibiotic, that is monobactam. In monobactam group, we have only one drug. The drug name is Aztreonam. And this Aztreonam, it is an IV drug. It is given for the treatment of only and only gram-negative infections. It is only effective in gram-negative infections or gram-negative bacteria, like very well we know typhoid. Similarly, Pseudomonas, they are gram-negative infection. But remember, it is not the drug of choice. The only place of Aztreonam in today's world is, we know that beta-lactams like penicillin, cephalosporin and carbapenems, they can cause allergic reaction. But Aztreonam was the only beta-lactam which has no cross allergy. And the basis we have discussed in previous section that it does not causes any cross allergy with penicillins, cephalosporin, and carbapenems. The only place we have. But the exception is, yes, this astronome can cause cross allergy with ceftazidime. With ceftazidime, it can sometimes cause cross allergy. Rest any other penicillin and other drug, no cross allergy. So this finishes our beta-lactam group of antibiotic. Let's talk about now other remaining cell wall inhibitor. So the next drug we have is bacitracin. In the previous section we discussed bacitracin also inhibits cell wall synthesis by inhibiting an enzyme bactrophenol dephosphorylase. And by inhibiting this bactrophenol dephosphorylase, it inhibits cell wall synthesis. Now this bacitracin, it is obtained from a bacteria. It is obtained from Bacillus subtilis. And this bacitracin, remember, it is only given as a topical drug on skin. And it is never given IV. Because when you give it IV, it is highly nephrotoxic drug. That is why it is only given topically and skin cream. And as a topical drug, it is given for gram-positive infection like Staphylococcus and Streptococcus. But remember, in Staphylococcus, it is not effective against one resistant strain of Staphylococcus, that is MRSA. We have discussed in the previous section the topical drug for MRSA was mupirocin cream. So next drug we have is cycloserine. So cycloserine is a bacteriostatic drug. That was an exception. Its mechanism of action we discussed, it inhibits one enzyme, alanine racemase enzyme and alanine ligase enzyme. Because of this reason, it inhibits cell wall synthesis. Now, the only use of cycloserine is it is given in the treatment of MDR-TB. MDR-TB is multi-drug resistant TB, in which we have discussed cycloserine again. The main side effect of cycloserine comes in CNS. And in CNS, cycloserine causes psychosis. It can cause psychosis. So in psychosis, it can lead to depression also. And because of the risk of depression, there is an increased risk of suicides with cycloserine. So after cycloserine, the next cell wall inhibitor we have is fosfomycin. We discussed fosfomycin inhibit enol pyruvate transferase in the previous part 1. And by inhibiting enol pyruvate transferase, it also inhibits cell wall synthesis in a bacteria. The use of fosfomycin is that it is given for the treatment of UTI. UTI stands for urinary tract infection, and especially it is given for the treatment of enterococcal UTI. Remember, enterococcal bacteria, it can cause urinary tract infection when we put Foley's catheter. From Foley's catheter, this bacteria from skin or genital area, it can go upward with the help of Foley's catheter and it can cause infection in urinary tract. Sometimes we call this type of UTI as COTI. COTI stands for catheter associated urinary tract infection. So what is the dose of fosfomycin in UTI? This was a recent question. Fosfomycin is given as a 3 grams oral single dose, which is available as a powder form in sachet, 3 grams oral single dose. So after fosfomycin, the last group of cell wall synthesis inhibitor is a very important group, glycopeptide group. And in glycopeptide group, we have a very famous drug name vancomycin. So vancomycin is a glycopeptide group of antibiotic, and the mechanism of action of vancomycin, because it's a glycopeptide, we can remember it inhibits trans-glycosylase enzyme. So again, glyco word is coming, and because of this reason, it inhibits cell wall synthesis of a bacteria. Now, after vancomycin, we made a drug, teicoplanin. So it has some different name, but it is a very important drug. Teicoplanin, very commonly we use in our hospital in our country. Other new drugs, they will end with the word vancin. Uritavancin, telavancin, dalbavancin, which is vancomycin-like drugs. Now, how vancomycin inhibits cell wall? Just write one point that it inhibits this enzyme after binding to one cell wall component, that is D-alanine. When vancomycin binds to D-alanine, after binding it inhibits trans-glycosylase enzyme. Next point, vancomycin is a bactericidal drug. So the only static drug we have discussed was cycloserine. All other cell wall inhibitor were bactericidal drug. So sir, what do you mean by this word D-alanine? So let's see this part. This is a cell wall of a bacteria. And cell wall of a bacteria contains glycans. And these glycans, they are linked together by an enzyme, trans-glycosylase enzyme. Now this is the glycan part. Above glycan we have peptides. That is why the cell wall is peptidoglycan. And peptide, it is made up of amino acid D-alanine. So vancomycin, it comes and it attaches to this D-alanine moiety. When it attaches to D-alanine moiety, it inhibits the cross-linking of glycans. So this is the mechanism of action of vancomycin. This picture was asked in your exam. Now comes the question, how does a bacteria is becoming resistant to vancomycin? Bacteria changed its cell wall component. Instead of D-alanine, bacteria made D-alanine D-lactose. When the cell wall of a bacteria changed, D-alanine D-lactose is produced, then vancomycin cannot bind to cell wall, which leads to vancomycin resistance. So D-alanine changes to D-alanine D-lactose, which leads to vancomycin resistance. So let's see, where do we use vancomycin? Vancomycin, it is only effective against gram-positive bacteria. But in gram-positive bacteria, we mainly use penicillin group of antibiotic. So vancomycin, it is given in penicillin resistant cases of gram-positive bacteria. It is also given for penicillin allergic cases of gram-positive bacteria. So penicillin resistant and penicillin allergic cases of gram-positive bacteria, but vancomycin is not effective against gram-negative infections. So any gram-negative infection, if I say, sir, typhoid, Salmonella typhi, gram-negative, is it effective? Sir, you will say vancomycin is not effective against typhoid. It is not effective against Pseudomonas because they are gram-negative infection. So there are certain GIT bacteria, and these GIT bacteria are gram-positive. Although they are gram-positive, still they are resistant to vancomycin. So these bacteria, once they have been asked, and I will tell you the importance. L for Leuconostoc, not effective or not killed by vancomycin. Pediococcus, Erysipelathrix, and Lactobacillus. Now, these GIT bacteria, which are gram-positive bacteria, they are not killed by vancomycin. Can we say that vancomycin does not kill normal GIT bacteria? So, normal GIT bacteria or GIT microbiome, which is present in our body, good bacteria, they are not killed by vancomycin. So, let's see the uses of vancomycin. So, vancomycin is given in gram-positive bacteria, which is resistant to penicillin and resistant or allergic to penicillin. Keeping this thing in mind, intravenous vancomycin, it is the drug of choice for MRSA. So MRSA stands for methicillin resistant Staphylococcus aureus. Staph aureus is a gram positive. Methicillin is a type of penicillin. It is also the drug of choice for toxic shock syndrome, because toxic shock syndrome is again because of Staphylococcus and Streptococcus. It is also the drug of choice for ampicillin resistant enterococci. So enterococcal infection, again we give vancomycin, which is resistant to penicillins like ampicillin. Now vancomycin can we give orally? Let's see. Vancomycin, it is a highly polar drug. Polar means it is a highly water soluble drug, and water soluble drugs are not absorbed orally. So can you give vancomycin orally for the treatment of MRSA? Answer is no. Here we give vancomycin IV. But when we give vancomycin orally, although it will not come into your blood, don't you think it will kill one infection in GIT? This vancomycin will kill local infection in GIT. It is considered to be the drug of choice for the treatment of pseudomembranous colitis. Colitis means this infection is only present in GIT. Here we give oral vancomycin. It will not get absorbed, but it will kill this bacteria in GIT. This harmful bacteria in GIT, which is causing pseudomembranous colitis, this bacteria is Clostridium difficile bacteria. Similarly, it is also given for treatment of Staphylococcus enterocolitis. So how we can remember? You can see colitis word is coming in both of them. If colitis word come, give oral vancomycin. Although it will not get absorbed from GIT, it will kill this bacteria in GIT. So let's talk about the side effect of vancomycin. So vancomycin, it is highly ototoxic, nephrotoxic, and the classical side effect of vancomycin is it causes red man syndrome. So red man syndrome is histamine release from mast cells. So vancomycin can cause histamine release from mast cell, and we all know histamine causes vasodilation. And if there is vasodilation, can we say there will be flushing on skin? There will be red color rashes on skin. So flushing and rashes, they will turn the color of skin red. So it is known as red man syndrome. And this red man syndrome is seen when we give vancomycin IV. And when we give this vancomycin IV, very fast infusion, fast injection increase the risk of red man syndrome. Hence, to prevent this red man syndrome, as a doctor, you will give fast injection or slow injection. To prevent this red man syndrome, give slow IV infusion of vancomycin. Never give vancomycin fast. Fast will cause faster release of histamine from mast cell. That is why we have made one drug. The drug name is teicoplanin. Teicoplanin has no risk of causing red man syndrome. And another great advantage of teicoplanin, just like vancomycin, it can be given intravenously, but it can also be given as an intramuscular injection. So red man syndrome, remember vancomycin. Keeping this thing in mind, let's talk about a very important infection, that is toxic shock syndrome. So toxic shock syndrome, it is caused by super antigens of Staphylococcus and Streptococcus bacteria. So Staph aureus, Streptococcus pyogenes, they cause toxic shock syndrome. Now it is such a dangerous condition, the patient can go into shock and there is desquamation of skin. So skin will peel off. So what is the treatment of toxic shock syndrome? The first treatment goal is, don't you think we have to kill this bacteria, Staphylococcus and Streptococcus? And the second goal of treatment is, don't you think we have to reduce toxin production? Because this toxin is causing damage to the body. To kill bacteria, the drug of choice is intravenous vancomycin. And to reduce toxin production, the drug of choice is clindamycin. Why clindamycin? Because clindamycin is a protein synthesis inhibitor. Toxins are proteins, so it reduces toxin production. Very commonly asked question. So clindamycin to reduce toxin. But if somebody will ask you, sir, what is the overall drug of choice? Remember, one drug you have to mark, then mark vancomycin. If specifically asked to reduce toxin production, then go with clindamycin. Now the next infection is even more important, very commonly seen in our hospital settings, that is Clostridium difficile diarrhea. Now what is Clostridium difficile diarrhea? This infection, it is also known as pseudo membranous colitis. So Clostridium difficile, it causes pseudomembranous colitis. Now let's see how it happens. This Clostridium infection, it is antibiotic induced diarrhea. That means when you give antibiotic to the patient, these antibiotics, they can cause this infection, Clostridium difficile infection. Don't you think how ironical thing we are talking about? We are giving an antibiotic and infection is occurring. Let's see how it happens. When we give any antibiotic, don't you think these antibiotics, they will kill our normal GIT bacteria? So this normal GIT bacteria, when killed by this antibiotic, one harmful bacteria can grow now. Which harmful bacteria can grow now? Sir, Clostridium difficile bacteria can grow now in intestine. So when antibiotic kill normal bacteria, this infection occur, it leads to inflammation of colon, Clostridium difficile, it leads to pseudomembranous colitis. The main symptom is diarrhea. So one question comes in our mind, sir, which antibiotics have highest risk of causing Clostridium difficile infection? Highest risk are seen with 4 antibiotics. CCAF, first C stands for clindamycin, C for cephalosporins. Which cephalosporins kill gram-negative GIT infection? Third generation cephalosporin, best for gram-negative. They will kill GIT bacteria maximum. Ampicillin and fluoroquinolones. Fluoroquinolones like ciprofloxacin, levofloxacin. These 4 antibiotics, when given, they kill GIT bacteria. Clostridium difficile can happen. Even in this 4 antibiotic group, if somebody will ask you which antibiotic has highest risk, overall highest risk is by clindamycin. Clindamycin has overall highest risk of causing. So what is the treatment? Treatment of Clostridium difficile infection, we can make a mnemonic. Very famous business, make rich fortune. So V stand for very famous drug, that is vancomycin. So vancomycin will kill this abnormal Clostridium difficile bacteria in GIT and it will spare the normal GIT bacteria. And this vancomycin is always given orally. Remember, not IV. We give oral vancomycin. Another drug we have is fidaxomicin. So this fidaxomicin overall, it is the most effective drug. It is even more effective than vancomycin. Then we have one antibody specifically made for Clostridium difficile infection, beslatoxumab. So MAB means monoclonal antibody. Tox means this monoclonal antibody is against toxin, and B for toxin B of Clostridium difficile. So Clostridium difficile produce toxin in intestine which can lead to diarrhea. Let's block this toxin B, by beslatoxumab. Yes, this bacteria makes toxin A also. There are two toxin produced, A and B. So we have an antibody against toxin B. M for metronidazole. Metronidazole was previously considered to be a better drug. At nowadays, metronidazole is only given as an add-on drug to vancomycin-like drug. A new drug, rifaximin, which can be given. And F for, don't you think if this good bacteria are killed by antibiotic, we can replace this good bacteria, and these good bacteria can kill this harmful bacteria, Clostridium difficile. So we can do fecal microbiota transplant, or simply fecal transplant. Fecal transplant means replace this good bacteria. So fecal transplant is done for the treatment of which infection? For Clostridium difficile infection. So keeping this thing in mind, let's talk about what is the guidelines, what guidelines says. So if the patient is having first episode of Clostridium difficile infection, you can start oral fidaxomicin, which is even more effective drug than oral vancomycin. So if somebody will ask you what is the overall drug of choice, sir, you will say fidaxomicin. But in reality, fidaxomicin right now, it is not available in our country. If it is not available in our country, what we are giving? We are giving oral vancomycin. And this therapy must be given for continuous 10 days. If there is again recurrence, again this infection has occurred despite treatment, again give same treatment. But now give this treatment for continuous 30 days or 1 month of vanco or fidaxomicin. So if there is second recurrence, now this is an indication to do fecal transplant. You must replace good bacteria. Now imagine this pseudomembranous colitis, this bacteria entered into the blood. From colon it entered into the blood. Don't you think it will lead to sepsis? So if there is sepsis, there will be septic shock. Shock means the patient will go into hypotension and the intestine is damaged. It can lead to paralytic ileus. So this is an emergency condition. And in this emergency condition, we give the patient oral vancomycin to kill the bacteria in colon. Plus we add intravenous metronidazole to kill the bacteria which is circulating in blood, and we must add antibiotic beslatoxumab. So beslatoxumab like drug, they are given or reserved for fulminant type. That means when there is an emergency, we give this drug. So this is the management guidelines of Clostridium difficile infection. Now let's talk about enterococcal infection. Enterococci is a gram-positive bacteria. It has two species, Enterococcal faecalis and Enterococcal faecium. So people who are IV drug abusers, they suffer from enterococcal endocarditis, IV drug abusers, immunocompromised people. And when we put Foley's catheter, it can cause catheter-associated urinary tract infection. So first, let's talk about treatment of enterococcal endocarditis. Very dangerous condition. Give the drug of choice as intravenous ampicillin plus gentamicin. And in ampicillin resistant cases, or we will write ampicillin allergic cases, we know the treatment. We give IV vancomycin, which can be given with gentamicin. But what about enterococcal faecium? In enterococcal faecium, neither ampicillin is effective, neither vancomycin is effective. We straight away start IV daptomycin with gentamicin. And in vancomycin resistant cases, we again start daptomycin in cases of enterococcal fecalis. Now, how we can remember? Fecalis, remember A word is coming. In faecium, A word is not coming. So, A for ampicillin is started in enterococcal fecalis. Now, what about urinary tract infection by enterococci? We have already discussed a drug, phosphomycin. So, this phosphomycin is given 3 grams oral as a single dose. So this finishes our enterococcal infection. Let's talk about now, after cell wall inhibitor, cell membrane inhibitor. So the drug which inhibits cell membrane of bacteria are 2 drugs only, daptomycin and colistin. Colistin, it is also known as polymyxin E. There is one more name of colistin. It is also known as colistimethate. So for your reference, try to remember colistin word. Daptomycin, it is a lipopeptide group of antibiotic, while colistin is a polypeptide group of antibiotic. Both drugs, they inhibit cell membrane, and remember both drugs are bactericidal drug. Now where this daptomycin is used? Sir, daptomycin, it is a reserve drug for resistant gram positive infection or positive bacteria, like we discussed VRSA, vancomycin resistant Staphylococcus aureus. And now can you guess what is VRE? VRE stands for vancomycin resistant enterococci. What about colistin? Again, colistin is a reserve drug. Sometimes they are known as drug of last resort for gram negative infections. Now, in which infection we give? We give colistin in carbapenem resistant cases. Like example, if a question comes carbapenem resistant pseudomonas, which drug we give? Colistin. Carbapenem resistant Acinetobacter baumannii, which drug we give? We give colistin. Carbapenem resistant Klebsiella, we give which drug? Colistin. So any carbapenem resistant cases give colistin. But there is a point to be noted that this daptomycin, it is not effective in pneumonias. Why it is not effective in pneumonia? Because in our lungs, we all know there is surfactant. Surfactant is a lipid molecule, and a lipid molecule can neutralize or inactivate lipopeptide. So because surfactant inactivates or degrades daptomycin, not effective in pneumonia. What about colistin? Colistin or polymyxin E, they are not effective in 3 gram negative infection. We have to remember BSP. It is not effective in BSP. B for Burkholderia, like Burkholderia capacia, not effective. Serratia and Proteus infection, colistin is not effective. And the last point is colistin side effect. Colistin is again nephrotoxic and it is neurotoxic. So when given IV, colistin is a nephrotoxic and neurotoxic drug, and when daptomycin is given IV, it is not effective in pneumonia. So this finishes our cell wall and cell membrane inhibitor. Let's make a summary now. So which first generation cephalosporin Cepha word is coming? Cefazolin. They are used for surgical prophylaxis. Give before surgical incision. What is the drug of choice for meningococci, gonococci, typhoid? They are all gram-negative community-acquired infection. We give third generation cephalosporins like ceftriaxone, ceftriaxone, cefixime. Ceftriaxone was given by injection, cefixime is given orally. Third generation cephalosporin, which is effective against Pseudomonas. So we have to identify Z alphabet like ceftazidime, cefoperazone. Now ceftaroline, ceftabiprole, rol word is coming. They are fifth generation cephalosporin and they are effective against MRSA. Disulfiram-like reaction, don't give an alcoholic. Reduce fibrin level and renal safe. We discussed opera cefoperazole. Now what is the dose of phosphomycin for the treatment of UTI? It was given as a 3 gram oral single dose. Now the next question, vancomycin IV. It is the drug of choice for MRSA. It is also the drug of choice for toxic shock syndrome. And it was also the drug of choice for enterococcal endocarditis resistant to ampicillin. While vancomycin oral is given for pseudomembranous colitis caused by Clostridium difficile infection. Which drug causes red man syndrome? Massive histamine release from mast cell. Vancomycin with fast infusion causes red man syndrome. So which antibiotic itself can cause highest risk of causing pseudomembranous colitis? It was clindamycin. Fidaxomicin and fecal transplantation are done for the treatment of Clostridium difficile infection. Clostridium difficile, we all know, causes pseudomembranous colitis. Drug used to reduce toxin production in toxic shock syndrome. To kill bacteria in toxic shock, we give IV vancomycin. To reduce toxin production, we give clindamycin. Now, which antibiotic was glycopeptide? Glycopeptide was vancomycin. Which antibiotic is lipopeptide? Lipopeptide is daptomycin. And this daptomycin was given in vancomycin resistant cases, VRSA, VRE. Which antibiotic is polypeptide? Polypeptide is colistin, also known as polymyxin E. So this is about summary. Let's solve certain MCQs. So which of the following first generation cephalosporin is given for pre-surgical prophylaxis? So you have to identify Cepha word. Cepha will be first generation. So the correct answer is cefazolin. Which of the following is the reason of combining imipenem? Remember, imipenem is a carbapenem and it is combined with cilastatin. And we discussed imipenem gets converted into toxic form in kidney by DHP enzyme. Cilastatin inhibit DHP1 enzyme, dihydropeptidase 1 enzyme. It inhibits the degradation of imipenem into toxic form in kidney. So can you tell me what is the correct answer? Yes, A is the correct answer. Cilastatin prevents degradation of imipenem into toxic form in kidney. So which of the following drug is the drug of choice for severe Clostridium difficile colitis? The answer is vancomycin, oral vancomycin. Yes, you can give metronidazole also. but the first drug or always drug to be started is vancomycin. Sir, what about clindamycin? Clindamycin and cefoperazone is third generation. They themselves can cause pseudomembranous colitis or Clostridium difficile infection. They are never given for the treatment. Which of the following antibiotic does not interfere with cell wall formation? So cell wall inhibitor, we know the mnemonic, BBC getting famous. In B, we have beta-lactam, like penicillin, cephalosporin. So cephalosporin is a cell wall inhibitor. Getting means glycopeptide group, we have vancomycin. Vancomycin is also a cell wall inhibitor. C for cycloserine. What about clindamycin? Clindamycin is discussed in next part. It is a protein synthesis inhibitor. So it inhibits protein synthesis. So let's talk about the last question. Which of the following intervention is aimed in reducing toxin production in toxic shock syndrome? Remember, to kill bacteria, we give vancomycin. And to reduce toxin production, we give clindamycin. Clindamycin reduce toxin production. So the correct answer is D. So this finishes our second part of cell wall and cell membrane inhibitors. Best wishes. Thank you very much.